Good evening, everyone. Welcome to the 19th episode of Great Conversations and Talks. I'm Yashaleka Rajshekar, currently pursuing my second year at GCT. It's my immense pleasure to introduce today's speaker, Dr. Janet Light, an alumna of GCT, batch of 1983. I extend my warm welcome to our eminent guest speaker, Dr. Janet Light, and all the participants of our webinar. Dr. Janet Light Thompson received her bachelor's degree in Electronics and Communications Engineering from Government College of Technology, Coimbatore, the master's degree in Electrical and Electronics Engineering from Bharathiar University, and the Ph.D. degree in Computer Science from Avinashilingam University, Coimbatore. She is a professor and founder of Dotty Emergency Assistive Care, University of New Brunswick, Canada. Today, she'll be speaking on the topic Challenges and Opportunities in the Healthcare Sector. It's our honor to have you here, ma'am. Before moving on to the webinar, we have some ground rules. If the participants have any queries or questions, please use the chat box. With this, I hand over the session to you.
Thank you, Shuri. Today, I'm really glad to meet you all and talk a little bit from my experience after I left the portfolio of GCT. Going forward in my career, the research and the teaching that I have done in India as well as here in Canada, and with some of the experience that I have gone through in the past 3 decades, probably 3 to 4 decades. So I like to present some of the challenges and opportunities that are there in the healthcare sector. So at first, I probably would explain to you the needs that are in the healthcare sector, and give you some statistics from US as well as in Canada, and then explain a little bit about technology as enabler for better healthcare in some of the areas that I have worked with: ambulance services, 911, health monitoring systems, and some of the challenges and some of the solutions that I have developed, and at the same time present to you some of those immense opportunities that are there for engineers to bring innovation to healthcare. So if you look at the needs of the healthcare sector, the healthcare cost is prohibitive, and it keeps increasing with increase in chronic diseases and also with aging population. Now with the modern society, you would notice that people live longer. So when you live longer, you have more diseases to face. You would also notice that the hospital care is becoming expensive. Now, when people live longer, they live in assistive living conditions, and to give them a good quality of life, more autonomous living, then they need more improvements in healthcare. Now, it's been known that ICT, information, communication, and technology, can improve healthcare. So how much use of ICT in healthcare? Now, there are also so many automated tools for automation, flow of information from hospital to the patients and vice versa. They are in high demand, especially with smartphones. If you have an app, you keep track of the calories that you take, your activities. There are umpteenth number of tools that are available that you can use, and it can be connected to healthcare. Now, the newer computing paradigms such as pervasive computing, ubiquitous computing, body area network, wireless sensor networks, IoT, Internet of Things, cloud computing, AI techniques. Now, these technologies can make information go back and forth. So you can make talk, communicate with one another, patient to doctor, vice versa, seamlessly, even under harsh conditions. So the need is, this is the time for healthy, affordable ecosystems, and engineers have a major role in this. Now, giving you some statistics. First, I'll give you some from Canada. So you would notice diabetes in 2015, our population is low. It's around 35 million now. So in 2015, it was around 3.4 million people, 9.3%. And 2025, it has been expected to go to 5 million, which would be 12.1%. So that means the cost will increase 44% and 25%, and the diabetes prevalence will increase to 44%. Now, if you look at Alzheimer's, when people grow old, and nowadays Alzheimer's are hitting early too, so it's a common neurodegenerative disorder. People forget things and people wander, and sometimes people are aggressive too. So now you would notice that in Canada in 2012, we had around 747,000 people living with cognitive impairment, some kind of Alzheimer's. Now, the cost that the care for those Alzheimer patients, the cost involved comes around 10.4 billion every year. Now, this is 2017 statistics, what I'm presenting. So now over the years, now we are in 2021, definitely is much higher than this. Now, looking at a little bit of US statistics, you will notice in 2017, the Alzheimer's and other dementia cost nationwide is around, right side, if you look at the slide, $259 billion. And in 2050, it's expected to go around $1.1 trillion. This is the cost of care. Now, so this is again 259 in 2017. This is with Alzheimer's. Now for diabetes, you will notice that in 2012, 29.1 million Americans, that is around 99.3% of the population, had diabetes. Now, you would notice that, look at the ratio. I've just circled the thing. You would find that 13% is the breakdown of the percentage of different ethnicity. And 13%, one of the highest, is Asian Indians. So Indians are prone more to diabetes. So that means more cost involved. So if you look at healthcare cost, what should we do? We need to cut down the healthcare cost due to increase in chronic diseases, increase in elderly population, increase in healthcare cost. Also, the shortage of healthcare professionals, especially here in Canada, we do have shortage of healthcare professionals. And location and living conditions to make it better. In the global scenario, because there's increase in the lifespan, so there are more diseases. Right now, we are in a pandemic. You know what that situation is, how much variants have come into scene in the past 1 year because of this virus. Now, in Canadian scenario, because this is where I did most of my work, so that's why I talk about Canadian scenario. But you as listeners, you can always, if you're from India, you can look at the Indian scenario too. You can study that. There will be some statistics that will be available, government statistics. So in Canadian scenario, especially in my province, New Brunswick, There is last 2 years reported decline in population. Usually population grows, but here there was a decline. One reason is the number of deaths were more than the number of births. So then also there was increase in elderly population. Now, 2 years ago, in one of my discussions with the health minister, 45% of the province budget is spent on healthcare. So you have only the rest of the money to provide roads, transport, infrastructures, and others. So if the healthcare itself here, the healthcare is provided by the government, by the province, whether you are rich or poor, it's the same care given to every individual. That is something very unique and precious in Canada, which is very good. But that comes with a cost. So there is a very intense drive to reduce the cost of healthcare, because only if you reduce the healthcare, you have enough budget money to spend on other infrastructure. And in here, our government spends around $72,000 per year for one elderly person for their care. So if you look at the map, you're going to see New Brunswick here. The right side, we are on the border, main border with US. So this is the estimated elderly population in 2021. This was estimated 5 years ago. It says 22.2, one of the highest, but right now it is around 18.6 or 7. I don't remember exactly, but it's 18.6, something around that. So this is our elderly population in our province. So how do we use technology as enabler? So there is growing evidence that ICT can improve the quality of care and patient safety. Now, electronic health, it's digital health. This is by using ICT. So it can reduce diagnosis time, even diagnostic cost, repetitive testing, and treatment cost. Remember, when you go to a hospital, you take all the blood work, scan, all kinds of things. And then when you go to another hospital, you do the same thing. So that's duplication. Also, thus you have to pay every hospital that you go. So with electronic health, they are all connected over the network. So then you don't have to repeat. So you take, in fact, I live in the city of St. John, where there are very good open heart surgeons. So people from other cities, they come here for the surgery, and then for their rehab, they go back to their hospital. So before electronic health, what will happen is they'll come here, do all the tests, and then when they go back to the hospital, again, blood test, all kinds of tests, they will do it in the hospital. But now with electronic health, which we do have now, it started around 2006, and I was part of this movement where we all went into electronic health. So with this, now they can come here for the surgery. They don't have to do blood works, because the blood works, if it is in the system, the group and the simple things that are there, you don't have to repeatedly do it. They can just take it from the system. And if there are scans, all that, you don't have to repeat here. And then when you go back to their hospital near their home, they can continue with the rehab. So electronic health has reduced treatment cost. Not only that, the repetitive testing, and remember going through all these needles to get all those tests done again and again. So there's been drastic improvement over that. Now, there's also, with more and more wireless networks mobility, there is more flexibility with telehealth and other stuff, that there's more improvements. Now, we can also have devices that are sensor devices that can capture physical data remotely and send it. So if you want to check your blood, sugar, there are glucometers that you can use to capture it, send it through from your cell phone and send it through wireless network to the doctor. So also with electronic health, you also get some historical data. So if you are a heart patient, then the system shows that you're a heart patient, then treatments are done differently. So if somebody passes out, if you know what their historical background is, then suitably they can give the treatment immediately. So lives can be saved. So, elderly don't have to drive to the hospital to do the testing. We can do it from home and send the data to the hospital. And also homes can be provided with monitoring systems, so that such as in a smart home, and monitoring of different physiological functions can be done remotely. I have done some of the studies and I'll show you some pictures as we go. So I'm here giving you some healthcare monitoring projects that I have done with my research team. My research team always consists of students, masters, and sometimes undergrad students, senior undergrad students, and then masters and PhD students. Done some on the ambulatory system, 911, elderly care, fall monitoring, sleep monitoring, predictive and proactive monitoring. So when a 911 call is made, in India, you have the 108 emergency call. So the ambulance shows up. In our system, the 911 call is also connected to the fire, the police. So sometimes not only the ambulance, but it's also connected to the fire and the police. It depends upon the case. So if it is an accident, then probably there will be ambulance as well as police. But if there is an accident due to fire, there will be fire service. So depends on the event that generates the 911 call from the home. So these services are put into action and then they collect the data. So earlier what they did, they used to do pen and paper work, and then they take the patient to the hospital. Then they will report that data to the emergency division. So until they brought the patient to the hospital emergency door, the hospital didn't know who was coming and what their situation was. So we developed a tool that from the ambulance, you can collect this data for their vital signs, and connect also to their previous historical data, and pass on this information to the hospital. So before they arrive, this data will be ready for them so that immediately they can start treatment. And some of the treatments, for example, for heart attack, they say the golden hour, within the first hour, they have to give that medication that would stop the future heart attacks. So if not, they will get more severe after that hour. So for paramedics in the ambulance, here they don't have the permission to administer that needle, that injection, until they get approval from the doctor. So then here, with this tool, they can send the data, the doctors can send the approval, and they can administer that in needle or the injection on the while they were transporting the patient to. The response time here in New Brunswick is 10 minutes and maximum 20 minutes. In India, the traffic, it could vary, but here it's much faster. But even then, this tool was very helpful in saving many lives. So we developed this. So the mobile agent, it could be a laptop, it could be a smartphone, it could be a notebook, and then sends it to the hospital. We developed the middleware that will convert this into the message. Now here we have, I mentioned about electronic health. So we have HL7 standard. It's global, health level 7. So there is a protocol for communicating between the client to the hospital server in HL7. We developed the middleware that took care of it. We also made sure that the wireless networks, we were earlier talking about connectivity. So if the connectivity is poor, we don't want to lose the signal. So then the mobile agents that we used will make sure that the data is not lost. It will store and then forward it when it comes to areas where the signal connectivity is more. So those are my students testing in ambulance. In fact, the girl that's sitting on the left side, she's from Coimbatore. Now she's teaching at Ph.D. Tech. She was here doing Ph.D. with me. So we developed that middleware. We called it, agent-based mobile middleware architecture. AMA makes no significance here in Canada, but we know what it represents. It was nice. We developed it and we tested it. We collected in St. John area, 300 test samples. And and we developed also the standard in that. So this is what a tool looks like. And then in HL7, and every message that sends to the hospital has to be acknowledged. So on the screen, you see the inside small screen. So that is the acknowledgement screen. But on the left side at the bottom, you would see hard code. So here, when an ambulance transports a patient, in India too, unless it's serious, they won't blast the lights, flare the lights. So if it is a hard case, then they'll flare the lights and it'll be sent quickly. But if it is not, then we call cold case. Then when there is data, especially when it is busy, so when there is more time for them, then they can send in the data leisurely. So this is one of our products. What did we do next? First, we developed for the ambulance, but as I told you, it's also connected to fire and police. Now we also have airlifting ambulance. We have in India too. Bangalore, I met with a company that provides airlifting. They bring patients from Bangalore to Coimbatore and vice versa. So then, again, to be connected, interoperability. They all work with different standards, different databases and different tools. So to connect them all, so we had to use some global standards. So we worked on it and did some good work on that. On the elderly monitoring, it's interesting that, you're always, drawn to some problem or some idea because something happened. One of my colleagues' mother, she was 92 years old. She was in the hospital, geriatric care. And in the night, she fell down from the bed and they picked her up dead only the next morning. So when my colleague was sharing this, I said to myself, there's definitely some better way of doing this. Why wait till morning to find out that she's fallen down and maybe because of that late care, she died. So I started doing fall study with the elderly. So, on the left side, you have a sensor area, or usually in nursing homes here, the elderly have a room. That's where I conducted my study. But at home, there are also other rooms that can be connected. I've done some study on that too. And collect all the data, send it through internet and send it to the hospital system. And suppose if it happened as an accident, then the ambulance can be alerted, family members can be alerted, doctors can be alerted, healthcare provider can be alerted. So this is our system that we developed. So we used Shimmer, which is an accelerometer. If you see that, the figure with the shimmer on the hip. And then we used Enobia sensor, that is to capture the brain signals. My idea was, if brain controls our movements, so if you're going to fall, the brain knows before we are going to fall. So capture that brain signal and try to predict fall so that we can prevent. But we also used other sensors like cameras, fixed cameras, moving cameras, motion sensors, even bed sensors, toilet sensor. Sometimes people become sick, they visit toilet too often, then how do we know that they are sick? So toilet sensor will tell them. Door sensors, Alzheimer patients have the tendency to wander. So if you're not watchful, they could wander and they don't know how to go back. So the door sensors would say when they leave the room. So we had a bunch of sensors for elderly care, captured all the data and processed it. Some process it on site, some we sent to the server side, and the server did the processing. So what did we monitor? What are the things we monitored? Did the subject leave his or her room? When did they leave? The time left and the time returned. If he or she left after sleep hours, then we immediately send an alarm or because from the motion sensors, you will get that information. And if they left after sleep hours, that means they are wandering, then it will send an alarm. Now, bowel movements from the floor pressure sensor by the toilet. So if it is more frequent, again, it will send an alarm. Fall from bed with the bed pressure sensors. Unusual behavior. Pill medication, they're all in old age. They have to take medications for sugar, blood pressure, and all kinds of stuff. So there's a camera on it. So that will tell if they had taken that medicine that day or not. Then the movement monitoring. So with all this the monitoring that we did, we developed our own monitoring solutions. The three of them, Shimmer, an accelerometer that I showed you in the waist, tied to the waist. Then Enobia, a biosensor for brain signal capture and sleep monitoring. And also we used it, as I told you, the brain will know better or before a fall happens. What's the purpose in picking up a person after they fall down? They're already injured. So it's better to predict. So we're trying to predict using the brain signals. And then the smart skin in the, here in Canada, you can't walk barefoot. Always we wear shoes or shoes often, especially elderly. So we put pressure sensors in the shoes to predict fall. How did we do? So I'll go through some of them. So the Shimmer one we developed working with the Harvard Sensor Lab. In fact, Gautam is now in Italy. I had some Italian students working on this project with me from Pisa, and some researchers worked on me in this. So student did his PhD under me, and so I took him to the Harvard Sensor Lab, and we had some work going on with them. So we developed for high fidelity motion analysis, and this can be used even for Parkinson, epilepsy, stroke, and so on, but we used in elderly care. The Shimmer itself, it's an accelerometer, it's developed in the Harvard lab, had a long life. That's one of its advantages. Also, it used a small, tiny operating system, and it performed much better than the other systems those years. So in our fall study, I'm putting in some technical data, so those who want your brain to listen a little bit, sometimes it gives you a little bit more interest to know details. So an accelerator magnitude peak, which was greater than 3G, it was the threshold that is used to detect a fall. How did we do it? We had to make all kinds of measurements. Sometimes we pushed people to fall, and we took different types of falls, sometimes people sit on the chair hard. So how do we distinguish real fall from all these other kinds of data that are happening? So I'm going to show you some figures. So if you look here, left side, real fall, that is how the fall signal looks like. On the right side, class B, you would see lying quickly on an elastic surface. That is how the signal looks like, the accelerometer signal. And down class A, the C, you would find sitting quickly on a soft surface. So class B, sitting quickly on a medium hard surface. So we want to isolate all this and pick only the real fall. If you don't isolate all this, there'll be a lot of false positives. So the alarm will go and then you will notice that they just sat on the couch. So you don't want to do that. So you isolate all these patterns and take only the one that is a real fall. And we use 3 grams. It's the, the value there as a threshold, above which we identify it as a fall. And we did this by testing. We didn't push elderly down, but some of our students, we had to push them down a number of times. And I had some cushion on the floor so that they don't get hurt. So here we have the signals that we capture. And so some of them are active because sensors, accelerometers, they're active. Brain signals, they're active. Some of them could be passive, like the bed pressure and the toilet pressure sensors and so on, passive. Put them in a virtual hub, and it does some processing there and sends the data to the hospital and also to the healthcare systems. And if an alarm or emergency, then the alert is given to the caregivers. Sometimes the data is given to the physicians to make their decisions too. So this is a system that we developed and tested. Now coming to sleep monitoring, I don't know how many of you really think what happens in your sleep. I'm going to give you a little bit ideas on what happens when we sleep. Okay, so we used sensor, biosensor, developed by an Novia company. It's a Spanish company developed in Star Labs. It can record EEG, ECG, and EOG. EEG is the electroencephalogram brain activity. Electrocardiogram is ECG, that's the heart, and EOG is the eye movement. So if you look at the picture, there are 4 squares on the brain. So those are the biosensors inside. They are placed on the forehead. It didn't work over the hair, so you have to put it in front of your head. But also remember, forehead is the part of the brain that also controls the movement. So that worked well for me. So if you look at the brain data, it consists of 4 types: beta waves, alpha waves, theta waves, and delta waves. Some of your brains could be now doing beta waves if you're listening intensively. So when you're doing mathematical calculations and all that intense brain work, then it's in beta waves. But when you sleep, it goes down from beta to alpha, theta, and then delta. If you notice delta, it is slow waves. So that is how the brain works when you sleep. So if you look here, the fall data, the one that I have shown here on the right side, so this is what the fall data looks like. This is actual data that we captured. So when you sleep, as I said, it goes through different waves. And there is one type of wave that is called, one portion of the wave that's called REM, rapid eye movement in sleep. So in sleep, when it goes through 3 stages. I think there's a slide, stage 1, stage 2, and then it keeps repeating. So then 20 to 25% of this 6-hour sleep, it's around 90 to 120 minutes, it is REM sleep. REM sleep is when you actually have dreams that you can recall. So if you can recall what happened, some dreams in the night, then that means that happened during REM sleep. Interesting, right? Okay, so look at some of the data that I captured. Again, this is from my Italian student. And it's interesting, I compared that data with mine. He was in his 20s, I was in my 50s. And definitely, it's interesting to know how our brain works, okay? Mine should have slowed down, but probably the GCT blood in me didn't slow down. It was really active, like one in 20s and 30s. Anyway, so this is, as you would notice, would be the beta waves. And then see, slows down when they go to sleep. So all night we used to record sleep data. And if you see here at the center, that's the REM. So that spike that you see, that's REM. So what we used to do, we used to capture this REMs and see how the brain functions, how many times they have been disturbed, how, all those studies we have conducted with those sleep monitoring. And there are tools with MATLAB. There are a number of tools that can help you to pick up frequencies, because here you would find it picks 6.1, 10, all those frequencies. So you can know which was more significant, whether it was the beta wave that was significant or theta wave that was significant. It also gives you the amplitude. So for each frequency, if you know the amplitude, then you can say which one was more prominent in your sleep. So, so I told you my plan was to predict fall, proactive care. You don't want to have something to happen and then give care. So how do we do it? Machine learning tools are used. So if you look here on the top, we are capturing the data and then sending it through wireless to a local network, then to the server side. And then what do? Do some data filtering to remove all the noise, pick up only the data, and then use data mining servers. So we used SVM in this case, support vector machine. So we used SVM, and this is how a sleep data looks like. Each data by micro volts, left side. And the right side is the timestamp that was taken over a period. So it's a timestamp. And so the raw data, it's taken, mean value, and then given to SVM. And the output of SVM will tell you, will isolate all the non-fall data and give you only the fall data, classifications. So here you see here 3 round ones, the red ones. Those are the 3 fall data that were in this sample list. So this is a pushed fall data. Again, if you look here, so the SVM push fall data, you can see those, the green one. So it isolates all the non-fall and then gives you the fall data. So you can predict, categorize that this data would lead to fall. So what you do is, here you would notice that's involuntary, that's push data and also the normal fall data. So you collect it over a number of people, use some of them for, at the bottom, if you look here, some of them are used for training and the rest is used for classifying. So portion of it is used to train the system, machine learning system. So it will learn. And then when the new data comes in, it will classify whether it is fall or not, or whether it will lead to fall or not. So if you look here, see there are 2 falls. It picked both those falls in our system. Okay, now with wireless systems that we have, now we are all connected. So there's no endless, there's endless opportunities for, improving the healthcare. So you have mobile data, mobile voice, even the backbone, the systems, they are at high bandwidth traffic. And wireless, you have different types of wireless, Wi-Fi. There are proprietary ones like GE wireless. They have quite a lot of healthcare monitoring products. They have their own wireless, Bluetooth, Zigbee, and then you have cellular data too. Now, so what are the major research areas? One would be at remote data collection point. I told you how I did with ambulatory services from remote, as well as elderly fall, those remote, that would be data collection. That would be one research or R&D areas that you can work. I have tools that I have developed for data capture. Communication platform. Now in healthcare, you have to make sure, if you really want to go higher, globally that it should be HL7 compatible so that you can use your platform to connect to the global system, and the other countries can also use your platform. Also in healthcare, security and privacy is very important. In Canada, privacy is very important. My children, when they were in their, now they are grown up, when they were in their 19, once they are 19, I have no access to their healthcare. So I will drive them to the hospital. They will go in, see the doctor, but the doctor will not tell me what is wrong with them because it is private from 19 onwards. So privacy is important. Also security. So the doctors don't believe in engineers because they think we don't give them a secured system that they can keep it secured. So I had done some work. So when it comes to security, confidentiality, who can access those authentication, message integrity. You don't want somebody who's live to be reported as dead or vice versa, and who can access data and to whom it's available. So always in engineering, we talk about Alice and Bob trying to connect, and Trudy is the enemy that is in between trying to, eavesdrop or capture that data. So in real life, Alice and Bob's could be a hospital system, it could be electronic health data servers, or the web browsers or the server that you use for electronic transactions, sometimes online payment systems, pharmacy systems. Here, the doctor will prescribe the medication, so we have to go to the pharmacy and collect it. So they're all done online. And in the networking side, it could be even DNS servers, routers, and other network components too. Recently, you heard about the cyber attack in US. So there are so many attacks that are possible. So we have some types of cryptographic systems that are already there. Public key cryptographic system, private key cryptographic systems, and also hash functions like MD5 SHA, and public key like RSA, elliptical cryptography, and so on, symmetric key, AES, DES, and so on. But since we are talking about healthcare, and already with monitoring healthcare data is available to us, we wanted to try body area network. So what did we do? The signals that we can use from the body, we used it for security, just like your finger signature. Now there you put the finger, you have to place the finger to get your authentication. Instead of that, what we were trying to do, because we are already monitoring all this data, why don't we use some of this data to use for authentication? So in our system, what we did, we had a body area network communication system that would capture the signals and send it either through wired or wireless to the system, medical server, hospital server, and the server will authenticate. So if I'm monitoring my glucose level, I don't have to take it and send it. The data is collected, my glucose level is collected, my sugar level is collected, and send it to the system. So for authentication, I'm not even pressing a button anywhere. It will use one of my physiological signals to do the authentication. In our case, we used, so it will log in, check whether I'm the person, and then it will either refuse or authenticate. Now, in our case, what we used, so this is what we call continuous authentication. So continuously monitoring this sugar, you will notice that, your parents or your grandparents, the sugar level will drop suddenly, or the heart will malfunction. So this continuous authentication uses our physiological signals that we are measuring itself to authenticate. So it's used for continuous authentication. You don't have to press any button. You just walk around doing your stuff. So what we used 2-layer authentication protocol. We used ECG signal, biometric, and we also use accelerometer signal. So we used in a parent-child relationship. So only the child is authenticated by the parent. And from user to hub, we used ECG. From node to hub, we used accelerometer signal. So this, they are captured by itself. We are not using extra devices to capture them. So we used a live heart meter monitoring system for ECG. And then we used VRemote. These are available in the stores. VRemotes, you can buy them. You can also use it as remote. They come with Wi-Fi capability. There's an accelerometer in it. So this is my student, again, a PhD student from Bangladesh with all this. But there are VRemotes that are smaller in size too, but this one was a bulky one that we got it. So he can walk around and he will be authenticated continuously from the data that has been collected. Now, to give you a little bit idea about how we do this research, so these are the patient data that is collected for so many minutes. So he'll walk around, do his own stuff, and we'll collect those data. And then we test it using the machine learning algorithm. So there are a number of machine learning algorithms. You want to know which one works better with this data. So we have BaseNet, SVM, quite a lot of algorithms that are there. And now, accuracy-wise, you find out which algorithm gives you better results. I mean, predicts better results without false positives. And recall rate, again, parameter used to decide the quality. And then training time, how much time does it take? Because you want to train quickly to get better results. You don't want the training period to be longer. Error analysis. So these are some of the parameters that we use to decide which one classifies, which algorithm works better with this data. Also, is it subject independence? For if it works with one person, will it work the same with the other person? So subject independence. So these are some of the parameters that we used. And then we also tried to see if we add more context to it, will it perform better? We used only ECG and accelerometer. Along with that, if you add activities, will it perform better? So these are some of the stuff that we tried to analyze. Then, so having done some of this work, I was trying also to again forecast, predict and forecast. So that was my plan all along. So using historical data and using some high-level machine learning techniques, how can I forecast emergency events before somebody gets a heart attack? If certain conditions, physiological conditions change, will I be able to predict that so-and-so is gonna get a heart attack maybe in next 1 hour, 2 hours, or even 5 hours? Even the fall, by taking the brain data, will I be able to predict and forecast that so-and-so may fall in the next 5 to 10 minutes or so? So we've been using deep learning techniques and so on and so forth. So this is some of the monitoring stuff that I've been trying to do. So probably I spoke quick. So to conclude, technology for sure helps improve healthcare. Some of my colleagues used to say, or some of even the medical people that I work with, they used to say, Janet, will we have the system ready before we go to that elderly stage? So, you know, technology for sure helps to improve, but how quick technology can be employed depends on the hands of engineers. Only engineers can bring it to work quicker. Nobody else can. So intelligent, remember you and I are very important for human society. Especially for healthy living, you and I are very important. Intelligent remote monitoring has brought tremendous improvement in chronic disease management and continuous health monitoring. Even you will notice the Fitband system can capture so many signals now. All you have inside is sensors. And using the data, you can even, find out how your body is functioning. So, but there are challenges at data collection points, data communication process, and security concerns, especially when wireless media is used. So choosing the right solutions, I showed you some of my ways of approaching the right solutions, protocols and security encryption algorithms. It'll improve the quality of healthcare, and it will reduce the cost of healthcare. Cost of healthcare. So far here in Canada, we are fortunate. We don't have to save or money for our healthcare because government takes care of us. Every rich and poor, it's taken care equally in a very nice way. So we don't complain, but it comes with a cost. So unless innovations take place, to bring down the cost, to reduce duplications, to make more remote monitoring available so that the doctors don't have to spend so much time with the patient, and the patient need not travel all the way to see a doctor. So if these things could be reduced, the cost would be reduced, time would be reduced, and better performance. And also knowing the historical data and predictions, some of this proactive care can be implemented. So automation is is the key to the success of health monitoring, also of a future healthy living. And engineers have a have a major role to make this happen. So thank you for listening. I just want to conclude with a picture of Niagara Falls. This is the US side. This is the Canadian side, Niagara Falls. And this is a winter shot. Now it's a springtime and summer soon, but this is a winter shot to my work. So thank you for your patient listening. I hope I didn't go too fast, but I'll be really glad to hear some questions from you.
Thank you so much, ma'am. This has been really an eye-opener for all of us, and to know what great service that you have been doing for the society and all your PhD students, how they have come up with such intelligent technology that can save lives. This is really an important a milestone that all of us have to keep in our minds, that what healthcare was there hundreds of years ago and where we have come so far. So thank you for letting us know that there is so much of a technology that is available and that is still under, and we still have a long way to go. We have a few questions from here from our students who are very much interested in electronics and also to about data collection and how can we use data. So one student has asked, ma'am, how can I start or how can I get data from hospitals? I am a student, and today I can get data from what is available on the internet. But for a country like India, how reliable can the data be collected?
Very good question. That's a challenge with my own students too. When I was doing my GCT final year project, we did ECG data acquisition. We had biomedical and we did ECG data collection. So we used to have our own students, our own group mates, project group mates as patients and collect their data. Collecting data is very hard. In India, you have private hospitals. If you have contacts, they might be willing to share. And I mentioned to you about privacy. Privacy is the key. Here, you will not get it from any hospital. Having said that, in my study, I had to go through research ethics approval. So for the elderly, I used the nursing home. So I had to get permission from the nursing home as well as the hospital and the University Research Ethics Board approval to collect data. And for that patient, especially for Alzheimer's, since they cannot give their, they cannot think properly and give, so their family has to give their consent too. But having said that, we ourselves have posted in university, for example, the fall date, I had a student, PhD student from University of Pisa, Italy, and on their lab data. So some of us have a lab database where we will post our data that we collected. Anonymous, you won't find the names there, but anonymous you will. Also, MIT labs have a number of patient database. How much it is accurate, I cannot say. Some of my students who use that data, because some of my PhD students didn't want to waste their time collecting data. It is hard. You have to go through all this process and it takes a long time. So then there are some open databases. So if you're looking for fall data, some are available. How far it is reliable? To some extent, to do some initial study, you can use it. I always encourage my students to take our own data, but it is time consuming. And you have to buy all those equipments, which are very expensive too, unless you have research grants to do that. So private hospital, if you have contacts, you can. But there are quite a lot of European and North American public databases where you can get some data. And some of those publishers, if papers that are published, you can write to those authors and they can share some of their data.
Thank you, ma'am. Thank you for that. And we have Pradeep here with a few questions.
Hi, ma'am. So one of the question I have here is, can any of your, project, whatever you have implemented, can it be scaled across other countries? Like, has it been already done?
In fact, that's what I'm doing. I have started a company of my own, Dotty Emergency Assistive Care. And some of the products that I have prototype tested here, the ones that I developed, they were all in India. I noticed, I was in India talking to some of those hospitals. You have medical tourism in India. So there are quite a number of patients coming from other countries to India. Sometimes they are airlifted and they come for treatment. So if their data can be shared. So some of the hospitals, they're very keen in my product. It is scalable, it is customizable. But in India, probably for example, the ambulatory tool that I have, it uses the global standard. So there are 660 fields in it. Probably all the fields won't make relevance in India, but it is scalable. You can customize it.
Awesome, ma'am. Thank you. And one more area that we are concerned is about the current crisis that India is going through with the pandemic. So would any of your solution be, handy for any small companies to take up and, deploy that? Because a lot of districts are grappling hard with this current crisis. So would any of your solution be, helpful in that front?
My solution, I worked with the Italian team where they did a little bit of localization. Now, what we are doing in Canada right now, not necessarily my solution, but contact tracing. So that is something in our province, we had kept, see on the south side is US border, on the other side is Quebec border. Quebec in Canada has had the highest cases, and US, as you know, had quite a lot of cases. So to protect our province from these two neighbors, it's a hard job for us. So what we did, the province as such, Canada developed a contact tracing tool, and we used it very intensively. So if somebody is found to have COVID, all their contacts were traced and they were isolated. So we kept the death toll very low. Only 4 people died, and 4 of them were very elderly and they had pre-conditions. So our fatality rate was very low, and overall we have managed it very well. So technology can help, but in this case, I don't think my technology is ready to do it. I have a classmate of mine. He has production. I noticed that one of your profits from production. He is production. He's in New Jersey, and he is developing something to tackle with COVID too. On similar lines, and me and him, we are talking with each other how we can do it, but not anything right now.
That's great, ma'am. So we are interested to learn more about the outcome of those discussions. So we'll keep us in loop.
Yes.
Over to you, Gautam. Yeah.
Thank you for that, ma'am. And medical tourism was another question that we had as a student was asking, and thanks for having your insights on that. We have Sundar Ganesh asking if, as undergraduate students, how do we kickstart our research work?
I can talk from what is available here. MyTax has a program where during summer they give you grants for preferably third years. They have to be a student to come here. It's 16 weeks program, fully funded, travel, expenses, everything fully funded. And India is in the list. I have had 2 students. One student came from Bangalore, one student came from Delhi. They work with my team here during summer, my research team, and they did a very good job. The reason this program is there is to attract students for graduate studies in Canada. So if they come on this summer trip, so when they come here for their graduate studies, they get $10,000 off their fee. They make it so attractive so that they come back. But in my case, one of them came back to Canada. The other one went to Harvard for his graduate studies. So there are opportunities. And I think the Harvard Sensor Lab that I worked with, also they hire quite a number of undergrad students, but not necessarily on summer basis, but over some period. So you have to keep looking what each country offers. And I'm sure in European Union too, there are some opportunities where you could go and work with those research teams during summer.
Thank you, ma'am. Thank you for that. And we're right on the clock. So that I would now request Akshaya to wrap up the session, and we would have our post discussions after that. Over to you, Akshaya.
I'm honored and lucky to have the opportunity to give a vote of thanks today. First and foremost, a big thank you to Dr. Janet Light. Thank you, ma'am. Thank you for your efforts towards the betterment of the people in need and for your insights on the healthcare sector. I must mention a deep sense of appreciation for enlightening us with your knowledge, particularly on this topic, a much needed discussion in the current healthcare crisis. Thank you, ma'am, for giving us deep insights into the topic and the point where you told us about the opportunities and the future in the healthcare sector was really informative. Thank you again. Secondly, I would also like to extend my gratitude to our Honorable Principal, Dr. P. Tamarai ma'am, Respected Dr. V. Prasannamuthi sir, Secretary of GCT Alumni Association, and all the participants in our webinar. Finally, I would like to thank our organizing committee for putting together this great talk.